Hello, so I'm going to be talking about all of the different views for the lower body um, and the setup that goes along with that. So first I'm going to start with the foot. So for foot we have A to P, medial and lateral oblique, as well as lateral. So the central ray for A to P is going to be at the base of the third metatarsal. And it's going to be the same for medial and lateral oblique. The only difference is we're going to have the patient's foot as they're laying supine, either rotated 45 degrees outwards with the lateral side touching the bucky for lateral oblique. Same thing for medial oblique. The medial side would be touching the bucky 45 degrees, and then the lateral foot would be, the foot is going to be laying flat with the lateral side against the bucky. Along the midfoot, of course, SID will be at 40. And so those are the views for the foot. Next we have ankle. So ankle views, A to P, medial and lateral oblique, as well as lateral. So it's the same for the foot. So for ankle, we have so it's going to be either in between the malleoli for A to P. Sorry, 1 second. Patient laying supine and the ankle is bent or dorsiflexed to 90 degrees. Once again at 40 SID, and it's going to be between the two malleoli. If it's medial oblique or lateral oblique, then it's going to be the same as the foot in the way that we're going to have the foot or the ankle turned either 45 degrees medially or laterally, depending on which side we're choosing, and that side would be against the bucky. So lateral would be against the bucky, or medial would be against the bucky, or sorry, against the against the bucky. All right, and yeah, once again, that would be parallel to the tibia and the malleolus, either lateral or medial. And then if it was lateral ankle, then we would have the patient with their ankle laying down on the side, on the lateral side, touching the bucky. Once again, ankle flexed at 90 degrees. So next we have tibia and fibula. So for these views, we're going to have either A to P or lateral, and we would have the patient standing, preferably for weight bearing purposes. But if both the inferior portion of the knee and the ankle doesn't all fit within the view, then we would have them laying. So for A to P, it would be mid-tib fibula, and we would include the inferior portion of the knee as well as the ankle as much as we could. And then if it was, say, lateral, then we would have that lateral side against the bucky. And once again, either standing or laying, depending on whichever would accommodate best for the views. And then finally, or rather not finally, but next we have knee. So for the knee, we have A to P, medial and lateral oblique, as well as lateral. So for A to P knee, let's see, we have the patient should be standing for these as well, as much as possible. However, I do see in these slides that we have the patient laying supine, so I believe that would be appropriate as well. So I'm gonna go with that. Actually, I'm gonna say standing if possible, but according to what I see they could also be laying just for the purpose of having that accommodated for that x-ray shot. So yeah, so we would have the knee fully extended, and the x-ray would go, or the central ray would go straight through the middle of the patella. It looks like there is also a tilt, so a 10-degree cephalad tilt to accommodate for the view of the entire knee. And of course we would only get what we need, rather a 5-degree cephalad tilt. And the central ray would be mid-knee. Now for medial and lateral oblique for the knee, we would have the foot, or the leg rather, rotated either internally or externally, once again with the side that we're looking for, medial side, rotated 45 degrees inward, or lateral 45 degrees outward, looking for what we're trying to shoot. Central ray, once again, it's going to be along the midline of the patella, but it's going to be the lateral border or the medial border. For lateral knee, we would have them with a Captain Morgan position if they're standing, but same if they were laying. So with the knee lateral side against the bucky, and then shooting just alongside the mid-knee crease there. So that would be this, there, yeah, there. So those are the knee views. There are, let's see, so there are special views as well, and those include the patella. So that's sunrise, sunset, skyline, and setcast. So for those, we would have the patient laying with a support underneath the leg, depending on how they're situated for which view. And so for these, oh, and I didn't mention tunnel view as well. So similar to the previous views, this one has to do especially with the knee joint, the whole knee joint. And we would have the patient bending their knees about 45 degrees, shooting from posterior to anterior, with the knee against the bucky, the patella against the bucky. And that would give us our intercondylar view, or the tunnel view of the knee. So for tangential patella, so we have the 4 views just mentioned: sunrise, sunset, skyline, and setcast. So we would have the patient laying prone for this one, and they would have the knee elevated, or rather the foot knee flexed. So we would have the knee flexed so that we could shoot from the, how do I describe this? So if I were to demonstrate, it would be like the shot would be coming in this way. It would be coming in from the inferior portion of the patella, coming in through to anterior. So yeah, once again, we would have that P at 40 SID, and that one is also posterior to anterior. So for these views, so that was setgast, yeah. Now let's see, is this skyline? I believe this one would be skyline. So for that one, we would have the patient supine with a knee bent, support under the knee if necessary, and we would be shooting from the superior portion of the knee here, coming in this way. So sunset, we would have the leg bent slightly more and shooting from that portion. Okay. All right. So those are the knee views. So we have femur and hip. So for femur, we have A to P and lateral. So both femur, hip, and pelvis, all of these we would have a shielding in order to protect the patient's organs. For A to P, we would have, for A to P femur, we would be shooting central right, the mid-femoral, at the mid-femur line. And once again, all of these are 40 SID. If it was lateral, we would have the lateral portion against the bucky and with the patient standing as much as possible. And we do include the knee and the superior portion, or rather inferior portion of the hip